Welcome to Wealth Well Done. Together, we'll cover a wide range of important topics surrounding money and the impact it has on our lives. From the sophisticated and highly valuable planning techniques of the ultra-wealthy to the commonly underutilized biblical teachings. Together, we'll work to improve our relationship with money and our effectiveness in stewarding it well. Here's your host, Eric Scovill.
Okay, welcome to the Wealth Well Done podcast, where we lean into the tactical, practical, and spiritual advice to help you do your wealth well done. Last week, we had Greg Downey on, and this week, we're going to start a new series. This is something we haven't done before here, and we're really going to try to serve three different purposes with this. We want to, first of all, educate you on some of the major topics going on in our world with people with firsthand expertise. We want to give you additional type of insight into private equity investments, what deal structures are, and what due diligence is. And then the last thing we want to do is let you see some of the specific deals that we are working in, our companies that we are working with. These might be companies that are we're actively raising money for, or that we have already done that in the past, and just help you see different investment opportunities as you go to look for what investments fit your portfolio best. And so just a quick disclaimer here, as always, that the content in this is meant to be educational and not meant to be financial advice for you. So please consult your own financial team to decide if these investments are right for you. That said, I am excited, first of all, to introduce my co-host here, Isaac Schaefer. Isaac's been a partner with us, and you are, and this is our first time having him on the podcast. So first of all, Isaac, thanks for joining here.
Yeah, it's great. Great to be here. It's fun.
Yeah, and so we're going to get to hear more of this. This one especially is right up Isaac's wheelhouse, and then our other two guests that you see on screen here are Greg Sturmer and Tom Jenkins, and they're from Elysium Therapeutics. And this week we are going to be digging into the opioid epidemic.
Yeah, so just as a little intro on myself, for those of you that might not know me, I actually have a background in orthopedic surgery. I worked for almost 7 years as a physician assistant in orthopedics. And this particular topic that we're talking about today, being the opioid epidemic and opioids in general, as well as pain treatment, is really near and dear to my heart because I prescribed thousands of scripts of opioids for post-operative pain. And so when Elysium kind of came on our radar, it really ignited my fire just because I have such a familiarity with the topic and with the medical applications and the challenges as well presented by opioids. And so when we became aware of Elysium Therapeutics, we absolutely wanted to partner with them. And I just want to take a little bit of time to introduce Greg and Tom to you guys and let them kind of tell you their background. Greg, let's just start with you. Do you want to just kind of start in the early stages of your career? I know you've worked for almost 30 years in healthcare now. So kind of where did you start off, and just give us a high level overview of, how you kind of got led to now founding Elysium.
Sure. Happy to. Way back, I started my career after university at a company called Arthur Andersen and Company, a CPA firm, but also a business consulting firm. Worked most of my time in the healthcare side with hospitals and health plans. And after, being a consultant for a while, I thought it was really exciting to be exposed to so many different businesses inside and outside of healthcare. But we always got to recommend strategy and never got to live through it. And so I decided to become a chief financial officer of a hospital that was struggling at the time, and it was kind of a turnaround situation. So became CFO there, worked closly with the board and the CEO to turn the hospital around, and happy to say that after all these years, the hospital is still up and running and serving the Sonoma Valley Hospital District.
That's awesome. Congratulations for that.
Thank you. And then decided it was time to check out the, working in a publicly traded environment. And that's when I moved over into biotech. So first company was Vivus, which was quite successful in its early years. Honestly, haven't followed them of late. I know they're still around. but I was corporate controller, but got experience with what it was like in late stage clinical studies because they were in phase 3. And then preparing to launch, we had geared up our own sales force. So got experience with what it takes to put together, a commercial operation. Then, so that was kind of late stage experience. Then I decided to jump all the way to early stage discovery.
Tom, how about you? You've been in it just as long, or if not a little bit longer than Greg. So how did you get started in your career, and then kind of catch us up to where Greg left off at you guys starting Elysium?
So we intercepted with each other about 30 years ago. So you can tell from the trajectory that Greg mentioned that we're pretty similar. Before that, I came out of Stanford in the early 90s. I was a PhD student in the chemistry department, specializing in synthetic organic chemistry. And at the time, the biotech sector in South San Francisco was just booming. And it was really compelling to take an opportunity to just go directly from grad school into industry. And I figured if I didn't like it, I would just stay there for a year or two and call it an industrial postdoc and move on to more academic pursuits. Turns out I really liked it. The chemists were, really in high demand. There was just tons of blue sky and opportunities. The analogy I like to use is there was a time when you could piss off your boss in the morning and pick up the phone and have another job by lunchtime. That's how crazy it was. So my wheelhouse has been in the discovery to early development through human proof of concept, and put a number of drugs through that cycle, including local anesthetics, some antibiotics, and more recent to my experience in the opioid area was a general anesthetic replacement for propofol, which you've probably used, I think, in your orthopedic cases.
A few times, yes.
It's the drug that puts you to sleep.
Yeah.
And then around 2004 was really when I got bit by the bug to get into this opioid area. And one of the primary drivers for that decision was the fact that a lot of the problems that were, associated with just generic opioids as they're currently used could be solved and addressed fairly elegantly with a chemistry approach. A lot of the early efforts in this field were done with physics. So people would make like gums and goos and, things that would make it harder to inject or snort opioids. But really the next level of attack on the problem and where you can really make a big impact is through chemistry and actually changing the molecule. So that's been our passion for many years now.
Yeah, interesting. And so can you kind of just walk through briefly as you got introduced to the opioid epidemic, and then the idea of approaching it from a different aspect of treating it from a chemical perspective as opposed to a physics perspective, because obviously that's getting much more down to the base problem. Just talk about kind of how that light bulb got ignited, and then going through the process of maybe this can and will actually work when you were when you started at Signature Therapeutics, and then how that now has led you to Elysium to kind of fine tune some of the things that you learned.
That's a great question. It's kind of an interesting thread. So my first company I worked for was a small company called Eris, which later got bought by Solera. And then to answer your question directly, the spark was talking to a clinician in the midst of the opioid crisis and asking me, gee, is there any way that you could make an opioid so that the only time the opioid got released is if you actually swallowed it like you were supposed to? And that instantly did to me. So I knew that there was a lot about this digestive enzyme trypsin, and I knew its substrate specificities, and I knew that I could turn an opioid using chemistry into a substrate for that enzyme so that the only way it would release the active opioid is if it was swallowed and exposed to that enzyme in the gut. So that's kind of the thread of how I got, was able to tie almost all of my postgraduate experience into what you see now today as the products of Elysium.
I want to back up a little bit and just make sure that we give some clarity around opioids. We're going to give you guys a bunch of questions here, a little bit more rapid fire. So just in a brief summary, what are opioids here? Both whether these are prescription or illicit.
Sure. So when you're thinking about prescription opioids, what most people will be familiar with are brand names like Vicodin or Percocet. The generic names are hydromorphone, oxycodone, hydrocodone, morphine. Those are kind of the typical names that you'll hear. And these prescription opioids are used typically because you've experienced some sort of trauma, whether it was from an accident or it was through a surgical procedure. And there's usually a window of time that, the pain is so severe that you need an opioid to kind of get you through those days. And that's kind of referred to as the acute use of opioids. Now, on the illicit side, you have what historically has been probably the most known is heroin, also an opioid. Interesting fact is heroin, I think, was actually introduced in the early 1900s by Bayer as some sort of cough suppressant. So it's come a long way. And so, but the drug you hear most probably, or opioid you hear most about in the illicit form today is fentanyl. So that's one of the other names you'll be familiar with.
Yeah, I think it's important just for as context for everybody to understand just the importance of opioids. Opioids are actually originally a derivative from a plant. It's a substance that's produced by the opium plant. It's been used for hundreds of years to kill pain. And the key there is that it is by far the most effective painkiller that we have. It binds directly to our pain receptors and basically blocks our bodies from feeling pain. And so it's incredibly effective and always has been for the last several hundred years since we've kind of understood the effects of opium. And I think the key there to understand is that even though we've known about the effects of opium for 100 years and the effectiveness, the way that we use it has really not changed much in those 100 years as far as the safety and safety measures that can be used within opium. The delivery mechanisms are basically exactly the same as they always has been, which ultimately has produced the opioid epidemic that we see today. Because while they're super effective at relieving pain, that also comes with some challenges and some risks. And so I don't know if you want to kind of talk about how from that standpoint and some of the risks associated with opioids in the context of the Purdue scandal, which a lot of people are probably somewhat familiar with, especially with some of the documentaries that have come out over the past, several years or so.
Yeah, there certainly have been a number of Netflix or other series kind of telling the Purdue story and what's happened with the opioid crisis. And really, I think that all would agree that the opioid crisis started in the 90s. Two things happened that were very important. And I was actually working at the hospital at the time, and I remember this very clearly. Pain became a fifth vital sign. So if you were in the healthcare service industry, if you were providing healthcare to a patient, you were held to a standard of how well are you caring for their pain. At about the same time, a company called Purdue, owned by the Sackler family, came out with a drug called OxyContin. essentially what they did is they took an existing generic opioid called oxycodone and put it in one of these formulation matrix that Tom affectionately refers to as gums and goos, and made this long acting. So that started this evolution from really where opioids were predominantly being used for acute use, so self-resolving pain. You experienced some sort of traumatic physical injury, you needed this opioid for a short period of time, and then you were off of it. Well, with the advent of OxyContin, what Purdue was going after was chronic pain. Okay, so all of a sudden, the chronic use of opioids became a thing. And, the sad part of it is, part of it is, maybe people trying to do good and there being unintended consequences. But quite frankly, there were some bad actors in here as well. And I think there's enough fingers to point in different directions, be they, pill mills, Purdue themselves, some doctors, distributors of drugs and all. But what happened starting in about 1995 is prescriptions for opioids took off. So it just started a rapid increase. And so there was good for patient care. I mean, we were doing a better job of managing care, but the unintended consequence is that opioid abuse and opioid overdose took off. And we went from a situation where there were around 3,000 fatalities a year from prescription opioids. It shot up to a record high of 17,000 fatalities from prescription opioids.
Thanks for that, Greg. I think as we were looking at this, the opioid use disorder, the latest numbers I had seen were that it was roughly 9 million people in the United States alone had this disorder, 16 million worldwide, to show you the massive problem on a worldwide scale. But huge component of that is sitting here stateside. The numbers that you threw out earlier, Greg, of when it went from in the 3,000s to, I think you said maybe 17,000 deaths, and then here, so in 2021 it was over 80,000 deaths.
And that's when you add in the illicit
correct.
Opioids. And
the stat that you used, and so webinar that we just hosted, the stat that you used that really stuck out to me is you said that's the equivalent of a 737 crashing every day. And if we we've got Boeing making the news for some whistleblower type concerns, but there's not a 737 falling out of the sky every day, and that would be get so much news and attention. Yet this is getting some documentaries, but this isn't. We're not getting change driven here as much as you would expect otherwise. And in 2022, it was almost 108,000 deaths. 2023, it's just slightly higher than that. Those numbers, I don't think they've been finalized yet, but it looks like they're going to be maybe closer to 110. And just looking at that, like just for one of those years, that's more than every U.S. soldier casualty we've had since the end of World War II. So, going back to 1945, Korea, Vietnam, Middle East, every war that we've had that many deaths die per year now in opioids here recently. So,
it's just devastating what's going on. And another aspect that's making this a challenge is because of the bad actors and some well-intended people that contributed, unfortunately, to the opioid crisis. There have been huge government settlements with pharmaceutical companies that were producing opioids, with distributors that were distributing them. We're talking multi-billions of dollars. And what those settlements have done, again, I think maybe in the world of unintended consequences, is it's really put a damper on just coming up with innovation in this space, right? People have been kind of scared away from the space when it seems that the answer, at least to Tom and I, was obvious. We've got a drug that's safe when used as directed, that has unmatched efficacy, but has some terrible inherent risks. Is there anything we can do to address, the inherent risks? Just to give you another interesting statistic, since that 2011-12 peak in pharmaceutical prescriptions for opioids, they've dropped 44%. There's been a 44% decline in prescribing, but the number of fatalities remain the same at about 17,000 per year. So what's wrong with that picture? That's because the pharmaceutical industry hasn't stepped up or been told they need to step up and make these products safer. And that's what we're working on.
Yeah, that's a great point, Greg. And kind of going back to what Tom said about, you can change the physics of trying to prevent people from abusing opioids. But ultimately, there's always ways around gums and goose and things of that nature. And until you address it at its most basic level, at the chemistry level, you're still going to have those inherent issues. Even if you pull back the number of scripts by 40%, you still have those inherent issues. And so I guess it would be good to hear just really quickly, because, some people think, oh, well, the opioid crisis is just because there's a bunch of addicts and we have an addict problem. And so I wonder if maybe, Tom, if you want to speak to that, the fact that it's not necessarily an addict problem, that a lot of these people are normal people that found themselves abusing opioids, either intentionally or unintentionally, or whether they're just uninformed. And so how does that process for normal people like us four who don't have a history of addiction, how would the four of us get addicted to opioids, which I think sheds light on why we're at where we're at, why we have this opioid crisis and it's continuing to cause so much suffering and so much death. So if you could just speak briefly to that, Tom.
Yeah, the analogy I like to use for that, just to describe like who's likely to become an addict, and think about Rush Limbaugh, Brett Favre, and Prince. You can't think of three more different people than that. And the physicians Greg and I talked to early on, when we probed that question, said, you just don't know. There's certain drug-seeking behaviors, but nobody wears a sign. And it could be anybody that gets, involved with it. And one of the problems that I think we can address with this, so there's the need for pain relief because of the way that the short-acting opioids work, and to cover a reasonable duration of pain and provide analgesia for a reasonable window. We're prescribing a lot of pills currently. And people are getting big jars of pills. And you might know someone who has a big jar in their medicine cabinet. And people do not usually give these drugs back. But what leads to this addiction, and another footnote on this conversation, if you've watched some of these specials on HBO where they're interviewing people that are in rehab that have been hardcore opioid addicts, they ask them the question, how many of you started going down the wrong road with prescription opioids? And everybody raises their hand. It's almost a unanimous thing, is that people don't just one day wake up and say, I'm going to shoot heroin today. So what's happening, we think, and we've talked to some addiction people in this area, but you can get into a cycle of misuse or abuse and reward with opioids. So with a current opioid prescription, we now know from doing human abuse liability studies, what's a dose that's really quote unquote liked, right? These studies are often called drug liking studies. And, for hydrocodone with its potency, it's around like a 20 mg dose, or 4 or 5 mg tablets will light up pretty good. That's a pretty light dose. So you get over your pain, you have a bunch of leftover opioids, you decide, hey, I'm gonna take a couple extra of these things, see what happens. You do it and you like it. And then you still have a full bottle of maybe 12 more of these episodes to reinforce that pattern and that behavior. And then you run out of opioids, and that's where it starts the seeking behavior, where you're asking friends or you're raiding grandma's medicine cabinet, things of that nature. So what you want to do is basically, when you give these drugs to people to manage, legitimately manage their pain, you don't want to have so many opportunities for abuse in that prescription. And you can really knock that behavior back simply by just denying them multiple opportunities to seek that euphoria.
Right.
And reinforce.
Yeah, and if you could also just briefly touch on, you said the most well-liked dose is about 20 mgs. What's that in comparison to, a typical lethal dose for someone? Say they're like, oh yeah, I took 4 pills, 4 or 5 milligram pills this time. I'm going to try and take 8 or 10, and maybe I'll feel even better. Where's that line when it comes to, a lethal level of a prescription? Yeah, so about 10 pills.
It's about 10, a 50 mg dose is lethal. Gets you into the lower edge of a lethal range. And when I say lethal, I'm talking about, post-mortem data where they've actually been able to attribute the cause of death strictly to the hydrocodone. Because as you know, there's a lot of polypharmacy behavior that complicates things where people drink or do other drugs. But just hydrocodone, around a 50 mg dose in a naive subject can kill you.
Yeah, and to give some people context, from myself prescribing thousands of scripts of opioids, after a typical orthopedic surgery, we would give people a 7 or 8 day script of opioids, and there's in that single script, there's about 8 lethal doses of opioids in that one script, and right now today, there are hundreds of thousands of people that have a legitimate script that are just a couple days post-op that actually need that pain control. But there are hundreds of thousands of lethal doses, if not millions of lethal doses right now for people that have legitimate pain that maybe even aren't addicted. And so I think that just kind of gives you an understanding of why we're in the situation that we're in. Not because opioids are bad drugs or because they're ineffective. It's because it's exactly for that reason that they are so effective. But they come with significant risks, and so those have to be addressed, which Elysium has done, and we'll get into that. When it comes to prescription opioids, we definitely covered that. But the most recent issues that are really plaguing our nation is from synthetic opioids. And we already talked about how normal opioids or the original opioids were plant-based. They actually came from a plant. And synthetic opioids are completely synthetic opioid derivatives. And Tom, I know you could correct me there, but ultimately, talk about the complications briefly, if you can. Just talk about the complications of why synthetic opioids are so much more of an issue, just from a potency perspective, and why that presents so many problems and so many additional deaths because of synthetic opioids.
So most of the synthetic opioids that are emerging or have established themselves, fentanyl being the classic example, there's 2 things about it that make it especially nefarious. It's extreme potency. So there's one of the synthetics, I think, is a carfentanil, which is an analog of fentanyl but has a little bit higher potency. If you imagine putting enough grains of sand in the zero of a penny's date. So if you have a 2020 penny and you fill up one of the zeros with sand crystals, that can kill you if you're a naive subject. And it's just insane. And I think the DEA, when they do these drug seizures, they often put it into terms of how many Americans it could kill. And I think Greg probably knows the number, but it's almost every American can be killed with the fentanyl that they're currently seizing.
Wasn't it last year there was enough fentanyl pills that the DEA seized alone last year that was like 350 million potential lethal doses just in what they caught coming into the U.S. border. It's just unbelievable. Exactly. It's staggering.
And the other side of it that makes it especially nefarious and is sort of the main impetus for our super program is you're seeing now pills, fentanyl pills, bags and bags of fentanyl pills, millions of them getting seized. And a lot of them are, candy colored, look like, Lucky Charms or something to be attractive for younger users. There's an expression, one pill can kill, and it does often. Sometimes kids will buy some fentanyl pills and they don't know the dose strength because nothing's controlled. And there's times when, 2 kids will die in a single, episode of abuse on these pills because the dose is just so much beyond the recreational dose of fentanyl. And what happens when you take it orally is it comes on very slowly and it lasts for a long time. And so what we like to just describe it as, so IV heroin, which Narcan was primarily designed to combat, is fast on, fast off. You inject it, you get a spike in your bloodstream, and then it clears fairly quickly. And Narcan's profile is fast on, fast off as well. So those two things were very complementary. And Narcan was serving as a countermeasure for that because its pharmacokinetics, or how it came on in the body and left, was very, very much complementary. But right now what we have are all of our countermeasures are fast on, fast off. But when you take an oral fentanyl, especially when you get up to a lethal dose of fentanyl, you're at risk for hours. And so you're trying to fight that window with just, quick little shots of Narcan. It's a risky thing, especially for individuals that refuse to be transported to the hospital or that are revived at home or in rural areas. So and then obviously the synthetic opioid thing, that the other attractive thing from it, from the illicit standpoint, is the same kind of mentality that happened when cocaine switched to methamphetamine. One of the big attractive things was, why should I go out in the jungle and grow all these, pick all these leaves and pay people to stomp on them with hydrochloric acid and then ship these huge bags of stuff around the globe, when I could just set up a lab somewhere and I can make methamphetamine as much as I want in, much more efficient production. And a lot of these synthetic opioids, especially these nitazines that are coming online, those things are really, really easy to make. Like someone who flunked out of grad school in chemistry could be an expert at making those on large scale.
Yeah, and now we're seeing I think it's for those of people that are kind of familiar with the fentanyl problem, they know that really most of these precursors for these synthetic narcotics that are coming across the border, most of those are actually precursors from Chinese companies that sell them in bulk to Mexico, whether legitimately or illegitimately, probably illegitimately, and then those get picked up by the cartel. And when we talk about how much it costs to actually produce these things, because everything's an economics question, and so I think that's another big thing that has kind of driven this illicit fentanyl market, is the fact that the cost that these bad actors have as far as manufacturing the fentanyl is far below what they're actually able to sell it for on the street. And so the problem is not only that the substance itself is dangerous, but the economics behind it for the people on the other side makes it even more dangerous because they're so motivated to continue that problem.
Absolutely. I mean, this is like cartel's dream world, because it's not only dirt cheap to manufacture fentanyl or other synthetic opioids, but they're so potent that you only have to put a little bit in for it to have that euphoric effect. But, cartels are not pharmaceutical companies. So Tom alluded to this. When they're manufacturing all these pills, there are no controls in place.
You mean they're not up to FDA spec?
Yeah, the DEA did tests on these pills that they have seized, and 70% of the pills had a lethal dose of fentanyl in them. I mean, so it's just a devastating situation. And now fentanyl is in virtually every illicit drug out there. So you may think you're buying cocaine or some other drug, but there's likely fentanyl in it in today's market. And, they are, I don't know any way to describe it, but they are business people as well. So they drove down their cost of goods sold, right? They got first, heroin users, people that are willing to inject some drug into themselves first. And then they started shifting to the bigger market, and that's those who just swallow pills. Because what I don't think has come up yet, but when you look at opioid overdose, 90% of the time, it's just swallowing pills. It's swallowing more pills than are recommended. It's not people that are injecting or crushing and snorting them. The big problem is just taking them. And that's why it's so difficult, as Tom said before. You can't point to a person and say, oh, there's an opioid abuser.
Right.
They're not all, in fact, the majority are not sitting on the side of the street with track marks.
No.
The majority of them are sitting in an office right now, pushing some papers around or, in the gym, whatever it is, normal people. Yeah, guys, I think that, this has brought some amazing context around really what the opioid issue is and why we have it. And quite frankly, I think we really highlighted the points of attack to try to address these issues. And so, I think it's hopefully we've ignited people's interest enough to stick around for the next episode, where we really talk about how Elysium has taken all of these points, all of these pain points that we just talked about, and actually addressed them in a way that is completely groundbreaking. So really excited to hear from you guys about that.
Yeah, absolutely. So thank you, Isaac, Tom, Greg. So with this, we will be on next week to really talk about what Tom and Greg have done to make the solution for the problem that we have set the stage on. So join us again next week. Thank you.
Thank you again for listening to Wealth Well Done. Be sure to subscribe to the show on your favorite podcast player, and together we'll continue to improve our relationship with money and our effectiveness in stewarding it well.